In this summary, we're going to talk about renal replacement therapy in the intensive care unit. In this topic, we will cover the indications to go on to renal replacement in the critical care setting. We will then cover the modes and finally make the trickier parts of hemofiltration made simple. This includes the tricky names you hear and the roles of anticoagulation. On the intensive care unit, you will commonly be prescribing the components of hemofiltration, so now we can get to the understanding of how it actually works. Firstly, nice and simple, let's talk about the indications for renal replacement therapy on the intensive care unit. The indications are the big 5. Firstly, hyperkalemia, which we quote as usually over 6. A metabolic acidosis with a pH less than 7.25, and we measure that this is metabolic in nature by comparing it to the base excess, which will be -10 if it's predominantly metabolic. Fluid overload with compromise such as pulmonary edema or symptomatic uremia. This could be in the form of encephalopathy or those at risk of clotting disturbances. Patients at risk of these are those usually with a urea greater than 35, but you may find that hemofiltration starts a little bit lower than that, normally around 30, but a normal setting will be 30 to 40. And finally, there are certain drug overdoses that can be treated with renal replacement therapies. Now, what is important is hemofiltration is indicated only if medical therapies fail to be successful. So we would still treat hypokalemia with the normal medical therapy, but if it was refractory, then we are indicated to consider renal replacement therapies. The common toxins that can be removed from renal support are remembered as BLAST. They are small molecules and they're also not highly protein bound. Therefore, the hemofilter can help with clearance. They are barbiturates, lithium, toxic alcohols such as ethylene glycol, salicylates and theophylline. Now, there may be other toxins where renal replacement therapy is indicated to help remove them, but don't worry, resources like ToxBase will help you identify these overdoses. So now we talked about the indication, let's talk about the modes of renal replacement therapy. This is crucial to understand renal replacement therapies in critical care. Now, most people will be familiar with dialysis as a mode of renal replacement therapy, but it's not the only mode. Dialysis, as I'm sure you will classically think of, is the mode where there is this countercurrent flow and then there's diffusion between the blood and a dialysate over a semi-permeable membrane. Our nephrology colleagues will mainly use this mode for their patient cohort. However, there is another mode, and that is hemofiltration. This mode relies on applying a pressure to the blood over a semi-permeable membrane. This pressure pushes water through the semi-permeable membrane, and then this drags solutes out with the water. The larger components of blood, such as red cells, do not pass through. Once this process is complete, a physiological replacement fluid needs to be added back to the blood in order to rehydrate it. Now let's break it down further for the differences between these modes. Between dialysis and hemofiltration, there are some really important points. Firstly, dialysis can be intermittent, important to outpatient renal replacement therapies. However, with that, you also need a good blood pressure, which most of our patients do not have. As a result, those with critical illness do not receive a pure dialysis mode as it would not be effective. As a result, we use hemofiltration, which is a continuous mode, but able to be performed in our shocked patients. For reasons we will come on to, in most settings, hemofiltration needs specific blood tests during therapy, which again does not apply to those sat in outpatient dialysis centres. Finally, it is worth noting that the two different modes filter out different molecule sizes better. with hemofiltration filtering out medium-sized molecules better than the small molecules that dialysis filters out. This becomes more important with drug clearance, but that is enough on this topic for now. Focusing now specifically on hemofiltration in critical care, let's break down the different modalities of hemofiltration. First, I want to address the names of these modes. You may have been on ITU before and heard CVVHF as an example before. You, like many of us, may have not known what it means or wonder why it is such a long acronym. But let's take the perspective of the nephrologist. The acronym is important because they have different modes. They have an intermittent option. They have different sources of dialysis, such as peritoneal dialysis. So as a description of a mode, it starts to make more sense. Our mode is firstly continuous, and also we take it from a vein and we return it to a vein, so that's CVV explained. Then we offer hemofiltration, so putting it all together, CVVHF. I have talked so far about the two separate modes of renal replacement therapy, and that was the hemofiltration and dialysis. To add a little bit more complication, you can get hybrid modes. So this would mean your modality of replacement in your ITU is either CVVHDF or the traditional straight hemofiltration. The benefits of hybrid modes is the clearance of molecules of different sizes. Different units will have different machines that can perform different modes. In practice, they do not offer a big difference, and we don't need to decide between the two. Usually your unit will offer one or the other. So let's move on. All modes are hemofiltration based when we talk about critical care patients. Whilst the majority of the time you will see these two modes, there are other modes. So let's touch on these briefly. The alternative modes include slow continuous ultrafiltration or SCUF. Here all you're doing is removing fluid and not replacing that fluid, which is useful in an unstable patient with fluid overload. Next is SLED, which is a hybrid mode, meaning that you are on the filter not for the 24 hours. It can be intermittent, but again, it's not often seen in practice. But it would mean stable patients can be more mobile whilst off the filter. However, for now, I want you to focus on what is on your unit. Your unit will do either CVVHF or CVVHDF, which again, in practice is largely the same. And now you know that this is a continuous mode where water is pushed out of the blood within a filter, then fluid is later added back to the blood, making this different from dialysis. So hopefully that makes sense. To filter on behalf of the kidneys, we need good access to the veins. So let's briefly talk about how we deliver hemofiltration on the ITU. Firstly, for this, you will need a vascath. This is a central line, but it has wider lumens. You need a really good blood flow for hemofiltration, so bigger is better. It is inserted in the same process as a central line, and we use the same common sites for it. Now let's talk about the last tricky part of hemofiltration. Now, there are no prizes for guessing one of the main complications that we get with this therapy. We're taking blood, we're putting it in plastic tubing, and then we're applying a pressure of a semi-permeable membrane. And funny enough, the blood doesn't like it, and clotting is a big risk. So let's delve into this a bit more, and with this we'll touch more on some basic physiology as well. So the filter. The filter is a disposable part of the circuit. We want this part to last as long as possible, and that is the aim of using anticoagulation for hemofiltered patients. Not only to minimise disruptions to treatment and to reduce cost, but if we lost a filter completely, that ends up with a blood loss of about 150 to 300 mils. So what are the options? The first option is citrate, which is most commonly used. However, in certain cases we cannot use it. Another option would be heparin. Heparin is applied to the filter itself, with some heparin getting to the patient, but often in small amounts. However, there are a few other options available to you. You may have an anticoagulated patient already, or in certain cases you may choose to heparinize the patient. This would be more of an extreme option, if you were really struggling to prevent clots on the filter. Other options are to use nothing in a coagulopathic patient, but this is hard to predict and monitor, so is often not used. Finally, prostacycling used to be more common. However, the studies show it's not as effective as citrate, so largely it is phased out now. So of the anticoagulants listed, you are probably familiar with most of these, but less so with citrate. So let's break down the relationship with citrate, calcium, and the clotting cascade. Citrate is commonly used in medicine. For example, it's in your blue top blood bottles. It works by binding to calcium. Calcium is a very important cofactor for the clotting factors. So for citrate filters, citrate is added before the blood passes into the filter. This binds with the available calcium, and now your blood, hopefully, when pressed against the semi-permeable membrane, will not form a clot. At the end of your filter, we then need to replace that calcium, so we add calcium back. This is called your calcium replacement. Next, the blood returns to the patient, and the remaining citrate is then broken down by the liver. So this is a really good time to talk about ionized calcium, which you will hear being talked about in a critical care and major hemorrhage setting. We use ionized calcium to monitor the effects of citrate and to titrate doses. Ionized calcium is different to the total bone profile calcium. Total calcium measures all the calcium in the blood, whether it is bound to proteins or whether it is readily available. Ionized calcium, however, is the active amount of calcium in the blood. This is the calcium that takes part in clotting or muscle contraction or is important for heart function. We need to use this for monitoring citrate because total calcium will measure inactive calcium and active calcium as the same thing. We may then be unable to see how much is bound to citrate, or we'll miss a rare complication called citrate toxicity. Citrate toxicity is where there is too much citrate in the blood, causing a functional hypocalcemia or a low ionized calcium. This is where the two blood tests highlight their differences. In citrate toxicity, the ionized calcium will lower. However, the total calcium will in fact rise. This is because we continue to add calcium to the patient when we filter them, but it comes bound by citrate, which is accumulating. Overall, the body has more calcium in citrate toxicity. It just, however, cannot use it. So what are the effects? Well, this includes tetany. So if you remember your clinical examination signs, either from med school or for PACES, this would include Trousseau sign. It can also be a cause of prolonged QTC and in subsequent arrhythmias. Overall, this is why we monitor ionized calcium closely for patients on a hemofilter. So finally, how do we choose the anticoagulation? In most cases, this is nice and simple. So let's look at the details. For the vast majority of patients, you will start on a citrate hemofilter. However, when there is a degree of liver failure, this needs to be double checked, and this is because citrate is normally broken down by the liver. So these need to be discussed with a senior, and then there is more of a nuanced question of how much liver failure do you need before you can't break down citrate, and that question is beyond the scope of this talk. So before prescribing the citrate filter, just make sure you check with a senior. Then there's a final two options where the patient is already anticoagulated or they're auto-anticoagulated. These are more difficult to monitor in terms of hemofiltration, but you may decide to not use anything at all. That may be appropriate. However, as citrate filter is relatively safe to a patient and doesn't significantly increase the systemic bleeding risk, it's also appropriate to use citrate filters in those. You may just want to discuss it with your senior first. Finally, a quick nod to the fluid removal process. A combination of critical illness and the kidneys not doing their job means your patient is at risk of fluid overload. We prescribe how much fluid we want to be taken off via the hemofilter, and this will be part of you filling in a prescription in the morning. However, do not stress about this. The decision about fluid balance is nuanced and far beyond the scope of this talk. So the decision of how much fluid to take off can be deferred until ward round, when you can ask the person leading the ward round how much fluid they would like off that day. So finally, what have we covered here today? Hopefully now you know the difference between hemofiltration and dialysis. The key point of hemofiltration is that we are able to perform this in a hypotensive patient, which matches our patient population. Anticoagulation is required for hemofiltration, and the most commonly used is citrate. If your patient is in liver failure, then discuss this with a senior. However, in most cases, citrate is a safe and effective way to filter your patient in the intensive care. So finally, thank you for listening to this talk on hemofiltration. I hope this has answered some of your questions, but has generated a few more which you can ask whilst on your placement. Thank you.